professors, doctors, and colleagues, I'm going to talk about nail basic anatomy. First, it's important to know that the nail is the largest and the most complex skin appendage. Development begins in utero between 7th and 8th weeks and to be fully completed at birth. The nail unit consists of 4 different ectodermal and mesenchymal components, which are the nail plate, which is the transparent part of the nail folds, which are the lateral and the proximal nail folds surrounding the nail plate, nail bed on which the nail plate lies, and finally the nail matrix, which forms the nail plate. This is another picture showing the nail plate and proximal and lateral nail plate folds. First, the nail plate. The nail plate is the hard, semi-transparent, slightly convex sheet which makes up for 1/4 to 1/3 of the entire length of the nail unit. Histopathology of the nail plate shows tightly packed corneocytes, which are termed onychocytes. There is abundant hard hair type keratins embedded in a matrix of sulfur-rich, high cysteine and high glycine tyrosine proteins. The nail plate is surrounded on the 3 edges by nail folds, 1 proximal and 2 lateral, and it extends as well under the proximal nail fold. Second, the nail matrix. The nail matrix lies completely below the proximal nail fold, being covered by it. The nail stem cells are completely found in the nail matrix. The superficial compartment consists of eosinophilic cells with condensed nuclei. At the time of onychotization or nail plate formation, these cells lose their nuclei and abruptly transform into onychocytes. The nail matrix contains melanocytes that are inactive in lightly skinned individuals that can be activated by chronic repeated trauma. However, in dark-skinned persons, nail pigmentation is physiological, so it's not a disease in any dark patient. The main function of the nail matrix is to form the nail plate, and in order to know the origin of the nail plate, we should know the parts of the nail matrix, which are the dorsal matrix, intermediate matrix, and ventral matrix. The dorsal or the proximal part of the nail matrix gives the dorsal surface of the nail plate. However, the distal or ventral part of the nail matrix gives the ventral surface of the nail plate. The clinical application is that damage to the proximal matrix leads to nail surface alterations. However, damage of the distal matrix only disturbs the optical coherence of the nail. So surgery to the distal matrix is preferable to proximal matrix. Third, the nail bed. It's important for a nail as the matrix. When the plate is firmly attached to it, the plate shows its normal transparency with the paint nail bed appearance. It extends from the distal margin of the lanula to the onychodermal band as shown in the arrow. Histologically, the nail bed normally lacks a granular layer. However, the presence of a granular layer is a sign of pathology. The hyponychium, it's responsible for the physiological separation of the nail plate from the nail bed, forms the distal grooves and is strongly keratinized. It prevents foreign substances from entering under the nail plate, sealing the subangular space. 4, and the last piece of the macroscopic anatomy of the nail is the nail fold. We have proximal nail fold, which is a narrow wedge of tissue covered with epidermis on its dorsal and ventral surface, and we have the lateral nail folds framing the nail plate and giving support. The cuticle is the strip of cornified epithelium that adheres the nail at the edge of the proximal nail fold. It acts as a seal. So damage to the cuticle results in a predisposition to inflammation of the nail fold, so it shouldn't be removed. The lateral nail fold gives support to the nail plate and guides the longitudinal axis of nail growth, which compress the nail plate from each side, contribute to its transverse curvature. This shouldn't therefore be sacrificed in the treatment of ingrown toenail. Blood supply of the nail. There are 2 dorsolateral and 2 ventrolateral arteries that lack an internal elastic lamina that allows free movement of the nail and the fingers. There is communication between these vascular networks. In cold environment, there is constriction of arterioles and arteriovenous anastomosis within glomus bodies that maintains blood supply to the distal digits. We're going to say some biological and physiological facts about the nail. In contrast to the hair, nail growth remains continuous, lifelong, and is not cyclical. It's also not hormonal dependent. Fingernails grow about 3 times faster than toenails. So the rate of fingernails growth is 2 to 3 millimeter per month, but the toenail growth is 1 millimeter per month. So complete replacement of a nail after treatment requires 6 months for fingernails and 18 months for toenails. Second part of my lecture is about nail biopsy. We're going to take a quick hint about nail biopsy. Contrary to popular belief, a nail biopsy seldom leading to scarring. And for a good result, we must know why, where, and how to take a biopsy. Why to take a biopsy? For diagnostic and therapeutic issues, for the diagnosis of onychomycosis, melanonychia, nail psoriasis or lichen planus, and malignant melanoma. And for therapeutic benefit in nail bed tumors and the glomus tumor. And where to take a biopsy from? We can take biopsy from any of the 4 microscopic structures of the nail that we mentioned before, from the nail plate, which is the easiest and the least scarring type of nail biopsy, and reserved for cases with an onychalized nail plate, which can be clipped easily by a nail splitter. We can take a biopsy from nail bed, which is the most common type of biopsy performed on the nail unit. This is the site. If the site is chosen perfect, it can yield a wealth confirmatory histopathological information about the disease in the nail. Nail matrix biopsy is reserved only for lesion arising from the nail matrix. Technically, it's the most difficult and leading to scarring, so it's not done easily. Finally, you can take a biopsy from the nail fold, from the proximal or the lateral nail folds. It's indicated for paronychial dermatosis, whether inflammatory or tumors. How to take a biopsy? It's important to know that we need effective local anesthesia, as the nail is very highly sensitive structure with a large number of free nerve endings. We're going to discuss few techniques of nail biopsy, which are excisional biopsy, in which the whole nail is excised. It's generally applicable to tumors growth arising from the nail bed or nail matrix, and most commonly glomus tumor. Punch biopsy, in which we use a punch that retrieves a cylinder of tissue from the suspected area of pathology. Punch diameter must not be greater than 3 millimeter for matrix biopsies and not more than 4 millimeter for nail bed biopsies. The punch hole may be stitched. Shape biopsy, also known as tangential excisional biopsy, is recommended for the nail matrix origin of longitudinal melanonychia. This is a picture to sum up the nail plate biopsy techniques. Thank you.